RCC or renal cell carcinoma or hypernephroma or Graves tumor or adenocarcinoma of gut. Whatever it may be, it is a kidney tumor. Okay. Adenocarcinoma of kidney, it is the most common malignant tumor of the kidney and it is seen in the age group 50 to 70 years with male preponderance. That is, male to female ratio will be 2:1. It is also called as hypernephroma, which is a misnomer. It has been given that name with a belief that tumor arises from the adrenal crest because of the resemblance of these tumor cells with the clear cells of the adrenal cortex. So hypernephroma is a old misnomer. Coming to renal cell carcinoma, it is now known that renal cell carcinoma is an adenocarcinoma arising from tubular epithelium. That's why this renal cell carcinoma is also called as adenocarcinoma of the kidney. The other name for this adenocarcinoma of the kidney is Graves tumor. Coming to the etiology and pathogenesis. The etiology and pathogenesis of the renal cell carcinoma will be four. One is tobacco, second is genetic factors, third one is cystic diseases of the kidney, and fourth is remaining risk factors, whatever the other risk factors that are involved in causing RCC. Tobacco, it is a major risk factor for renal cell carcinoma. Whether you chew it or smoke it, whatever it may be, it will account for 20 to 30% cases of the renal cell carcinoma. Cigarette smoking will have twofold increase of developing the renal cell carcinoma. Coming to the genetic factors, it can be hereditary or sporadic. Okay, clear cell, sporadic, papillary, or hereditary. So the genes may be VHL gene or trisomy 7 or some other 17 or whatever it may be. Okay, so they all come under genetic factors. Cystic diseases of the kidney, as you know, that causes also renal cell carcinoma. Other risk factors include the persons who are working in asbestos factories and who are exposed to asbestos, heavy metals, and petrochemical products are more prone for renal cell carcinoma. This can be asked in MCQ. So this is a occupational health hazard. In women who are taking estrogen therapy or who are obese, they are more prone for renal cell carcinoma. And the persons who are taking regularly pain relieving tablets or painkillers, they are going to be caused with effects of analgesic nephropathy, which will ultimately result in or end up in renal cell carcinoma. And there is an entity called as tuberous sclerosis, which is of prime importance. This will have increased risk factor for renal cell carcinoma. Classification of RCC. Simply for easy remembrance, I will say one thing: C, 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 C. One C is clear cell carcinoma, other C is chromophil carcinoma, or which is also called as papillary carcinoma. Third one is chromophobe carcinoma or oncocytic renal cell carcinoma. And fourth one is collecting duct carcinoma or Bellini duct carcinoma. Along with this, one more variant, sacromatoid type, and the other is granular cell type are there. Total 6. The incidence will be more for clear cell type, which is a non-papillary one, followed by papillary and followed by granular, followed by chromophobe, sarcomatoid, and collecting duct. So, which is the rare type? Collecting duct type is the rare type. Genetics involved in clear cell will be, it can be sporadic and familial. Homozygous loss of VHL gene, which is located on the chromosome 3, is involved in clear cell type. Coming to the papillary, it can be familial and sporadic. Familial cases because of the mutation in the MET gene on chromosome 7. Sporadic cases will be because of the trisomy of chromosome 7, 16, 17 and loss of Y chromosome. Granular, both sporadic and familial. Chromophobe type, multiple chromosome losses will be there and hypodiploidy plays a key role. Okay, coming to the histology, as the name itself is saying, clear cell type, it will be, we will be able to appreciate the cells which are clear. having clear cytoplasm because of the glycogen and lipid accumulation in the cells which are not stained in HND. So we will be able to appreciate clear cytoplasm. This is a well differentiated tumor. Papillary type, in this we will be able to appreciate the papillary pattern, and along with this some of my bodies will be there. Granular type, there will be abundant acidophilic cytoplasm and marked atypia. Chromophobe type, it is a mixture of both pale clear cells and with perinuclear halo and granular cells. Sarcomatoid, the name itself is saying there will be whorls of atypical anaplastic cells. Collecting duct, it can be tubular and papillary pattern. RCC, it commonly arises from the poles of the kidney. This is a viva question, okay? And it is a solitary and unilateral tumor and most often seen in the upper pole. And the tumor is generally large, golden yellow and well circumscribed as shown in the picture. Papillary tumors have grossly visible papillae and may be multifocal. Cut section of the tumor may show cystic changes, hemorrhages and some types of ischemic necrosis. This is a picture from Harshmohan, where you can see a tumor in the upper pole. This is the renal cell carcinoma with areas of hemorrhage and necrosis. It is showing a large and tan mass. Rest of the kidney will be reniform only. Okay. Circumscribed yellowish mass with areas of hemorrhage and necrosis with compressed residual kidney on one side. Clear cell carcinoma. This is the most common pattern, 70 to 80%, and it arises from the proximal tubular epithelium. The tumors are arranged in solid pattern separated by a delicate vasculature. Tumor cells will have clear cytoplasm. So they are having clear cytoplasm and they are separated by delicate vasculature. Okay, clear? The clear cytoplasm is because of the glycogen and lipid from the cytoplasm during the processing of the tissue. They are being removed. So it will look like clear cytoplasm. And residual parenchyma will be compressed, seen in the peripheries. So this is a picture showing clear cell type RCC. So the most common congenital abnormality in clear cell will be deletion of the 3p, chromosome 3, that is VHL gene. This is also a picture showing the from Harshmohan practical book, renal cell carcinoma, clear cell, solid pattern and glandular pattern seen. Okay. Papillary type renal cell carcinoma, this is the second most common. After the clear cell, it is the second most common. It is also called as chromophil and it arises from the distal convoluted tubule. The most common type of renal cancer in patients who develop dialysis associated cystic disease. So papillary type of renal cell carcinoma is associated with dialysis associated cystic disease. The tumor cells are arranged in papillary pattern over the fibrovascular stalks and the tumor cells will be cuboidal with small round nuclei and some of my bodies will be seen. Cytogenetic abnormalities seen in papillary carcinoma of renal cell carcinoma will be sporadic is because of the trisomy of 7, 16, 17 and loss of Y chromosome, and hereditary is because of trisomy 7. For clear cell, it is 3. For papillary, it is 7. So this is a picture showing all the papillary type of RCC cells, cuboidal. Okay. Chromophobe type arises from the intercalated cells of collecting duct. These will have prominent cell membrane. Okay. and there will be a halo around the nucleus. Perinuclear halo is a characteristic feature of chromophobe type. If you see these cells, see there is a clear halo around the nucleus. Okay, and on electron microscopy, you will be having a numerous 150 to 300 nanometers microvesicles, which is the single most diagnostic and defining feature of the chromophobe cell carcinoma. Cytogenetic abnormality includes hypodiploidy or monozymic due loss of multiple chromosomes 1, 2, 6, 10, 13, 17, 21, and Y. Okay, hypodiploidy you should remember. Coming to collecting duct or biliary duct carcinoma, it is the least common type of RCC, and it will arise from the medullary collecting duct, and the cells will have prominent fibrous stroma. Coming to the clinical features, there will be triad of symptoms. One is gross hematuria, other is flank pain, other is palpable abdominal mass. Gross hematuria is the most common feature, characteristic feature of this renal cell carcinoma. This renal cell carcinoma will present paraneoplastic syndromes, which can be endocrine or non-endocrine. Non-endocrine are amyloidosis, anemia, neuromyopathies, vasculopathies, nephropathies, coagulopathies, prostaglandin elevation, dysfibrinogenemia. Whereas endocrine includes most of the 20% will be hypercalcemia, 20 to 40% will be hypertension, polycythemia in 3 to 10% of the cases, and non-metastatic hepatic dysfunction. This non-metastatic hepatic dysfunction is called as Stauffer syndrome. It is seen in 1 to 8% of cases. There will be galacturia rarely. Cushing syndrome is also rare. Alterations in glucose metabolism resulting in hypoglycemia is also rare. Hirsutism, amenorrhea, and male pattern baldness are also seen, but they are rare. So, paraneoplastic syndromes, endocrine and non-endocrine. In endocrine, hypercalcemia, hypertension, polycythemia, and Cushing syndrome. You have to remember this. And non-endocrine can be amyloidosis or anemia. Stauffer syndrome is non-metastatic hepatic dysfunction. Spread, it is spread to distant sites via hematogenous spread or local. Hematogenous spread will be to the lungs. It is the most common site, followed by brain and bone. And it may spread locally to the liver and perirenal lymph nodes. The striking characteristic of RCC is its tendency to invade the renal vein, in which it may grow as a solid column of cells, and it will extend up to the inferior vena cava as far as the right side of the heart. So, invading the renal vein is characteristic striking feature of RCC, and renal venous invasion is seen in 4 to 9% of cases. Coming to the prognosis, the overall 5-year survival rate will be 70%. Presence of metastasis, renal vein invasion, and higher nuclear grade of tumor are some of the predictors of poor prognosis. Clear cell is having a good prognosis, and collecting duct is having a worst prognosis. Please like, share, and subscribe Dr. Ravichandra Official for such interesting videos on pathology.